Welcome to the November Parkinson's Diner with the Doctors Van Laar. Thank you as always. And they'll be discussing, especially Dr. Victor Van Laar, the B1 therapy in Parkinson's disease, a popular topic. And thank you all for joining. And please take it away, Victor.
Hi, everyone. Good to see you all. So yeah, let's talk about the thiamine and B1 therapy in Parkinson's disease today. So let's start out with, hold on a second. Sure that slides, there we go. One very important thing I want everyone to take away from this, we're just presenting the facts as we see them, what's available out there already, and giving our perspective on it. But we're not recommending, promoting, or anything like that for any of these therapies or protocols. If you want to use any of these protocols, you got to talk with your healthcare professional. I mean, we can't give medical advice, nor should what we say here be construed as medical advice. So with that disclosure in place, let's start with what is thiamine? What is it for? So thiamine is also vitamin B1, sometimes called thiamine. And it is an essential micronutrient. It is something that we have to eat, that we have to take in. And it serves as an important enzyme cofactor for the cell. Now, what does that mean? Well, that means, like, we all know what proteins and enzymes are. There are certain enzymes that require an extra partner to get their job done. And B1 is that extra partner for a lot of really important enzymes in the body. And we use a lot of it. The half-life of thiamine when we take it in is only about 17 days. And what we take in gets very quickly exhausted, which is why we need to eat a balanced diet all the time, and why things go bad if we don't eat for like a week. So just as an example of what we're talking about when we say thiamine is a cofactor. So when thiamine is taken in, we don't use thiamine as is. The thiamine has to get modified. It gets what we call phosphorylated. It has these phosphorus groups added onto it. And once it's in that form, it gets used by various enzymes in the body. And these enzymes are absolutely essential for the body's ability to make energy, break down glucose, specifically breaking down glucose, and then having the carbohydrates enter the citric acid cycle in the TCA cycle in the mitochondria, where more energy, the ATP, the energy of the cell, is made. It's also responsible for breaking down and building up amino acids, the building blocks of protein. So basically life kind of depends on thiamine. And here are three primary examples of where thiamine latches onto very essential proteins: pyruvate dehydrogenase, transketolase.
Hey, can everyone see his screen? Or is anyone else having problems? Okay.
Nope, just you.
Okay, then Donna, maybe try to come back into the meeting and see if that helps.
Yeah, sorry about that. I don't have chat on.
Or
so
Vicky, sorry. Yep.
Oh, there's the chat. Okay, hold on one second. Yeah, try to come back in. I'll pause.
Probably should move on.
Yeah, how about moving on? Then
yeah,
we have a recording, so she can catch up.
All right. So these are three examples where it's essential to help these proteins do their job efficiently. and make energy for the cell. So that's what thiamine is and what it does when it's in the body. Now, where do we get thiamine? As I mentioned before, almost all the thiamine that we get, that we need, we get from our diet. Our body does not make it. It can modify it, but it can't make it. So food sources for thiamine include whole grains, beans, peas, meats, particularly red meats and fish and white meats. And basically, the typical Western diet, shall we say. Now, the problem is, we also live in a world with a very processed food diet problem. And a lot of grain processing can remove a lot of the micronutrients from the grains. As a result, because these micronutrients are so essential, many cereals and flours end up getting enriched with thiamine. So if you're buying white bread or cereal at the store, it probably has had thiamine added back to it. We're also able to synthesize vitamin B1. It's exactly the same as you'd find in your diet. And these can be sold as supplements and as medications to treat diseases where there is a thiamine deficiency. So there are disorders that cause a loss of thiamine, which is what that rest of that sentence was supposed to say. So example is the most typical example of thiamine deficiency is a disorder called beriberi. This is chronic thiamine deficiency. Now, most often this is the result of a severe lack of thiamine in the diet. So for example, this is very common in sub-Saharan African cultures where their primary food source is cassava root, which is really high in starch, but really absent in thiamine. Another example is in some Asian cultures that eat processed or polished rice as their primary food source, which has very low thiamine, or has had the processing and polishing has removed the thiamine, as opposed to brown rice or long grain rice. The results of this thiamine deficiency can be muscle wasting and neurological disorders, cardiac disorders. Beriberi is broken up into several groups. I'm not going to get into all the science of that, but some examples of beriberi that can affect the brain and the nervous system are Wernicke's encephalopathy, Korsakoff syndrome, which is also referred to as alcohol amnesia disorder. And what actually happens here is that anterograde and retrograde memory are affected and can lead to amnesia, and particularly in alcoholics. And then Wernicke-Korsakoff, which is the worst of both worlds.
This is a very unique syndrome to this condition. And this is where, it's a very unfortunate situation. It can be a little bit hard to recognize at first, but then you realize they start making up stories to try to explain their situation. And you realize that all of a sudden something just wild comes out of their mouth about, I had a patient who was in the hospital and they came up with this really wild story about how they got there, but couldn't realize they were actually in the hospital. So this is really a direct impact from the loss of thiamine that's secondary to the alcoholism. So this is how we know what it looks like when you have big depletions in thiamine for long periods of time. These are the neurologic consequences of that.
So then, why are we talking about Parkinson's disease? Is there a basis for thiamine deficiency in PD? And what's the basis for thiamine therapy as a treatment for PD? So this is where things get interesting when it comes to the B1 protocol and thiamine treatment for Parkinson's. So where this all started was a Italian physician, Dr. Constantini, worked by them and others, found that high-dose thiamine was beneficial in treating fatigue and various disorders. Now, just based on the biochemistry of thiamine, it's easy to see why. thiamine is absolutely essential for these cellular processes that make energy. So it's the mechanism here is simply that if you boost thiamine levels, you boost the function of all of these enzymes, or you overcome a block that may be happening from a dysfunction in these enzymes, and the cells make more energy. Your brain has more energy, you have more energy. And so Dr. Costantini was testing this hypothesis in several disorders where fatigue is a major symptom. Ulcerative colitis, multiple sclerosis, and several other ataxias. Now, when it comes to things like ulcerative colitis and inflammatory bowel syndrome, those can be two things that can lead to thiamine deficiency because it's not being absorbed properly. Similarly, multiple sclerosis is, unrelated deterioration of the white matter that makes neurons work efficiently. As a consequence, the neurons are going to work less efficiently. And fatigue is often a very common symptom of multiple sclerosis. Now, things got interesting because they noticed that fatigue wasn't the only thing that got better. A lot of other symptoms seemed to show slight improvement, and they didn't have a very good explanation for this. Nevertheless, we know that mitochondrial dysfunction and cellular bioenergetics are a major contributor to Parkinson's disease, neurodegeneration, and in particular, the movement disorders and fatigue that come along with Parkinson's disease. So Costantini's team had a hypothesis to test this in movement disorders like Parkinson's disease to see if it could affect the fatigue in these disorders. And that's how this all started. Do we have any questions at this point? Okay.
There was a question about sources of thiamine supplementation, but you may have something coming up.
Yes. All right. Okay. So I click off of it, there we go. So is there a thiamine deficiency associated with Parkinson's disease? And the answer is not that we know of. There's very minimal evidence for there being thiamine involvement in PD. In most PD patients that have been assessed, thiamine levels, at least blood thiamine levels, are perfectly normal. Even in the patients in Costantini studies that I'm going to be talking about in a little bit, their actual serum levels of thiamine were perfectly normal. Now, there has been some work in animal models of Parkinson's that suggest brain levels, particularly nigral levels of thiamine, might be lower. But a lot of this has not been replicated. Similarly, there was at least one study that looked at thiamine levels in the CSF of PD patients compared to control patients. And their work suggested that thiamine levels were lower. Now, again, I put this out there, but with a word of caution that there were other issues with these studies. We could spend a whole day talking about what's good and what's bad about these studies, but the main thing to take away from here is that these were small studies and they haven't been replicated. So they're more anecdotal at this point within the scientific literature. They're out there, but it doesn't add up to good evidence that there's a thiamine deficiency in Parkinson's. But it's still absolutely something that we may want to continue investigating.
Just wanted to say, can go back real quick. There's just like was mentioned with ulcerative colitis and the IBS, there's a lot of gut dysfunction in Parkinson's too. And so it's thought that, this may be contributing to some of the issues. It's like particularly with the thiamine levels and PD. And then the other question is like, is it being, utilized properly? So, so one is like maybe not getting as much into the gut. It's not getting absorbed as well. And then even if it does get absorbed, maybe it's not being effectively used and then pulled into like, again, help with mitochondrial and that energy production. That's it.
So very timely for Tim's question, what is considered a high dose? So Costantini and his team developed what they call high dose thiamine or HDT therapy, or the B1 protocol for the treatment of these fatigue and these disorders. And we were talking high dose. So you can look back at their publications to see what they did. But the ranges for an oral dosage can go from 1 gram to 4 grams a day of vitamin B1. This is up to 4,000 times the normal recommended daily allowance. Now, as Amber mentioned, when you're talking about taking things orally, most of this is passing right through your body. Like, you have to take this much to actually boost absorption of thiamine. Conversely, in patients where there was very poor absorption and they just weren't getting the blood levels of thiamine up, Dr. Constantini would do intramuscular injections up to twice a week of 100 milligrams of thiamine, injectable thiamine. So patients were given up to 200 milligrams intramuscular injection. Now, this is going to be absorbed much more slowly and directly into the bloodstream through the muscle. So this isn't going to just pass through the body like it would through the gut. Like, you're getting most of this, which is why the two doses are radically different. But we're still talking thousands of times of the normal amount of vitamin B1 your body would normally have. So some caveats with this protocol, obviously, doses this high can lead to side effects if not properly monitored. Anything, there's always too much of anything. Yeah, your body's going to filter most of it, but they actually did see some negative effects in patients that were given too much B1 therapy. Another thing to keep in mind is the injectable form of B1. That's only available via doctor's prescription. You can't just go out and get that from the supplement store. So a doctor has to say, this is something you should try. The oral, of course, you can go out and buy oral thiamine, but again, strongly caution that you talk to your doctor before starting anything. Another caveat was, at least in Constantini's studies, B1 therapy was not a replacement for traditional treatment. The patients continued their Cinnamate or levodopa carbidopa at the same doses. This was just an adjunct therapy, meaning it was added to. And so taking B1 with the normal medicines is where they saw a beneficial effect. They saw some improvement in UPDRS part 2 and part 3 scores. Some people reported that their dyskinesias that were associated with their levodopa carbidopa on times were actually observed to be lower. So in general, patients reported a benefit, and there were 2 studies that looked at this. I'll get to in a second. But where I was talking about earlier, like, be careful. You have to be careful with these high doses. They noted that in some of the mild PD patients who already didn't have severe dyskinesias, they reported what they were calling B1 overdose, where basically whatever sweet spot the other patients were observing a benefit to their symptoms, these patients actually saw a worsening of their symptoms. And for these patients, it actually required stopping the B1 altogether, and then they started bringing them back at lower doses. This is all in their literature. So again, and this is the only place that that's listed. It's not like there is an existing protocol for what to do for B1 therapy and what's the right and wrong dose. Right? It's only in these couple studies and reviews, and that's it.
I just would add, I mean, there are protocols we use, like I said, for the Wernicke-Korsakoff's disease, and so I think this is not too dissimilar than to what we would do in the hospital. So I think that's probably what guided this. But how and if you should apply that to Parkinson's is a big unknown.
Yep. So, what does the science really say for the thiamine deficiency, B1 therapy, and their involvement in Parkinson's disease? So at present, there's only really 3 publications on this at all. One has 5 clinical cases from a study in Japan that looked at a Japanese group that actually tested American patients. gave them high oral dose of B1, and within days, patients reported they were able to come off their carbidopa levodopa. Three of the 5 patients were. This is a very, very small study, 5 people. They didn't follow them out for any length of time. This was only for a couple of weeks. Not much you can take away from that study. But then Constantini's group has conducted 2 small clinical trials where they've published their high-dose B1 protocol. Some things about these trials, they were both open label. Patients knew they were getting B1. There was no placebo group. One was a very acute study. It only had 3 patients. It's an even smaller study. And the patients were given the high dose for 15 days via oral intake. And the patients showed an improvement on their UPDRS. So within just 15 days. So this led up to the next study where they followed patients from 3 months up to almost 3 years. This involved 50 patients. Again, this was protocol. Most were given oral. Some required the twice a week intramuscular injection. All patients by 3 months were exhibiting improvements in UPDRS 2 and 3 scores. And this is where things, you have to be careful about what's said. So in their discussions on these studies and on the B1 website, the B1 protocol website, they say, miraculously, these patients remained stable. Their scores remained stable for up to 2 years, or up to 2.8 years. But that's all the farther they followed these patients out. So they say it was a long-term study, but 2.8 years in a clinical setting with Parkinson's disease is not what we would really consider a long-term study anymore. And when you look at the raw numbers of these patients, they actually did continue to worsen. Like the disease did continue to progress, but it was at a lower rate than was expected. So most publications out there would expect patients to UPDRS scores to worsen in a range of 2 to 5 points every year, and these patients were lower than that, but the disease was still progressing. So remaining stable, they're using stats as a crutch to say that they were remaining stable because there weren't significant changes in the UPDRS.
Well, I they need to point out here too, because it's a challenge I live with right now, but using UPDRS as a way of judging progression or not, this is not looked at highly. It's actually not, you're not allowed to use this anymore. And in part because, we've had a lot of drugs that have been able to change UPDRS, yet patients at the end of these studies don't feel like it's actually made a difference just by changing, these scores on a scale. So, it's just take this with a grain of salt, and just to say, there's the expectations for a therapeutic to actually go through clinical trial. The threshold is really high, and this wouldn't cut it.
Right. Oh, sorry. Hold on a second. There we go. So what does the science say? So is there even a proposed mechanism by which the thiamine is working? If thiamine levels aren't truly low in PD patients, and we're seeing these modest changes, significant but modest changes in UPDRS, what's really going on here? So Constantini's group does speculate on how the B1 therapy is working, but they don't provide us any basic science evidence of why it's working. One thing they do argue is that the disease-altering effects of the treatment are the only explanation for the lasting effects year upon year. But again, as Amber just said, this really doesn't cut muster for being a robust enough study to show disease-altering effects. The studies are not long-term enough, the N is not high enough, and there's no placebo group. And even though they argue on their website, oh, this argues against the placebo effect, no, placebo effect can really be that powerful that it can last.
Just for some frame of reference here, there are studies in which you can look out for over 2 years. So I think the highest is close to 4 years of placebo group in Parkinson's, and you could have what is it's rare to see it this big, but you can see up to 10-point improvement just in the placebo group. This is a huge change. Patients on prior, looking at this in another study, patients can feel about a 3-point change pretty reliably. That's like probably the minimum that you can feel a big difference with. So a 10-point difference, I mean, that is the difference between, a tremor that's interfering with activities and none. So, I mean, this 10 points is quite big. And there are some patients just with placebo that are able to achieve a 10-point difference just from placebo. So the mind is quite powerful. And, I think the way I've described this before, then one way to think about this is, a lot of reward and motivation is driven by dopamine. And yet that is the very system in which we are kind of messing with in Parkinson's disease. And so this is, it's kind of working against us when it comes to placebo effect. And I got to tell you, I think this is a big reason why a lot of, potentially promising drugs haven't made it through the full FDA approval and that sort of thing. This is a massive challenge in studying Parkinson's disease.
So another thing that Constantine's group speculates on is, well, if thiamine levels are normal throughout the body, maybe this is something very specific happening in the brain or in the populations of neurons affected by Parkinson's disease. That could be a possibility. There could be, we know that, mitochondrial disorder, mitochondrial dysfunction, metabolic dysfunction are problems in the neurons that are affected by Parkinson's. But again, we don't have any evidence of that. There's nothing published that would suggest this is the case, that these neurons, of the substantia nigra have a thiamine block. And this is, again, very hypothetical at this point. A nutritionist, E. Overton, speculated similarly that the excess thiamine could simply be overcoming bioenergetic effects that we know happen in the neurons in PD, thus improving energy production and cellular function, as I mentioned earlier. And, that could be a big reason for, improving mood, improving fatigue. The neurons are finally just making more energy beyond what they've been able to make. But we don't have hard evidence that that is what's going on. It's just speculation based on the biochemistry that we do know.
I mean, there's Adama brought up a question here. I'd like to take a minute here to discuss. So is Parkinson's really a mental illness based on the placebo effect? And no, I don't see it this way. I don't think anyone does. But I would add, the brain is incredibly complicated. There are 2 medical specialties dedicated just to the brain because it's that complicated, and that's neurology and psychiatry. And it's because that really shows you the 2 different elements of the brain. And so again, when it comes to working with dopamine specifically, this is really the neurochemical that we're trying to benefit and increase. It has a lot of effects on our motivation and our drive and reward. And so it is the molecule that is really implicated in a lot of cases in driving placebo effect. This is why I think it's particularly difficult in Parkinson's disease. It doesn't mean that it's a mental illness per se, because this is all happening without it's no volition by the participant themselves. This is purely just a function of Parkinson's disease and the way that it messes up with dopamine that then lends itself, that makes it more likely to have a placebo effect in Parkinson's disease. And I would say more so than a lot of other conditions. Now, this also then extends to other mental conditions that involve dopamine. So this is really a unique property, I think, of a disease that's impacting the dopaminergic system. But PD itself is not a mental illness alone.
I also wanted to mention, so Paul asked, what are the side effects of taking this 300 to 400 milligrams? So officially, in the world of medicine, there's no upper limit to B1 itself, to thiamine. We don't really have any evidence of overdosing on thiamine. That said, they did observe in these studies that for a select few people, there was a limit to how much thiamine was helpful, and after that, their PD symptoms were actually worsening. Again, we don't really have a good reason for that. We don't know what was causing that. all we know is that when those patients were taken then back off the thiamine and it was brought to a lower dose, they were back to seeing a benefit. So I don't know if they didn't know either, if this is drug interactions, or if this is now hyperactivity of the neurons being caused by so much energy. We don't have a good answer for that. But B1 itself is considered relatively safe.
Very much agreed. You know, you do tend to excrete a lot of it, which is part of why you might need to supplement. But from what I can see, the side effects are more like GI upset. At extremely high doses, I think there was some concerns for arrhythmia, but this is also not well reported. So I'd be curious if anyone's tried this regimen. What did you feel if you thought that it was too high? I think that would be helpful for us to know too.
Yep. So I think this is also a really good point.
Oh, you want to talk about overdosing?
And what symptoms? Yeah.
I had gotten up to 2,500 grams per day, and it was like the second or third day that I was at that higher level, and all of a sudden I was hit with pretty heavy fatigue. I even had trouble lifting my arms up and coming up and down steps. And I had suspected that I had passed my sweet spot, so I stopped cold turkey that next day, and still experienced some of the heightened symptoms, like the fatigue. The fatigue was the most, lack of energy fatigue was the most obvious one that I experienced when I realized I had OD'd and when I came off of it. And then I felt after I came off of it, after about 3 days, I was fine. I mean, I still had the symptoms at a level where they were before I started B1, but the excessive fatigue only lasted about a day or so.
Did you have benefit with fatigue at some point with a lower dose?
Yes, but I don't know what that dose was.
Okay.
That's why I started over.
Okay.
And this sounds similar to what was reported in these papers, is that some of these mild patients went from, modest improvement of their symptoms to suddenly worsening of their PD symptoms and worsening of their fatigue. And again, there wasn't really a good explanation as for why, because we don't really see this in most people that take high doses of thiamine. So again, this is an area that requires more study.
Agreed.
And which is why I think this is also a good time to recap, what are the differences in clinical trials? So yes, the B1 protocol website reports that Dr. Constantini conducted these clinical trials, but what kind of clinical trials were they really, and where were they at the stage of this being a really accepted, well-studied protocol? So when we look at clinical trial phases, in general, there's the discovery science end. This starts with the preclinical science. So studies in the lab on cells, on animal models, to really learn the disease, really learn the treatment, and make sure that it is safe in a biological system to start with. And funny enough, this is the part that's largely missing when it comes to the thiamine protocol. Can we assume thiamine is safe? These doctors have assumed thiamine is safe. So they kind of just jumped to, let's start putting it in humans. So the very small 3-patient example that was published, since this was done in Italy, they're not really given the same phases that we would do in a US clinical trial, but probably the best analog would be a phase 0 study. The first in Parkinson's patients, see what happens 15 days. Oh, they saw improvement in UPDRS. Phase 1 is a small number of patients, so like his 50 patients, but it's open label. They know what's happening, and it's just to evaluate the safety and the dosing. And the patients did receive different doses depending on how they responded to the drug. But what do we really need to say this is a viable drug? This is a viable protocol for treating Parkinson's. And for that, we need to start talking about, phase 2 studies, the studies that tend to be placebo controlled, more patients, really assessing the drug's effectiveness at these doses that were found in phase 1, showing that they're more potent than just a placebo effect. And phase 4 is just, again, an even more rigorous study with even more people to confirm the results of phase 3 and really move this on up. So, we're not there yet when it comes, we're still back here when it comes to the thiamine regimen. And not only are we back here, we're still missing these parts. Like, there's a lot of basic science that should really be done with thiamine so that we know, hey, in Parkinson's disease, is there actually a neuron-specific loss of thiamine that isn't reflected by the body's level of thiamine? Are we really reversing that by just pushing thiamine levels? That's all speculation, even though it's talked about in the B1 protocol circles. We still have a lot of work to figure out if that's the case. So when it comes to clinical trials, this is just your friendly reminder. These studies don't happen without volunteers. Safety is always a top priority. And not every clinical trial tests drugs. There are ones that test exercise. There are ones that test diet. So
actually, I do want to say that some of the best results are still with exercise, just as a little plug in there.
It's true. Some studies have placebo, some don't. Thiamine is probably a study that should have a randomized double-blinded controlled study before we can really start to sink our teeth into whether it's good enough or not. But if you are looking for clinical trials out there, keep in mind, if it's a legitimate trial, it's going to be listed on clinicaltrials.gov. You shouldn't have to pay out of pocket for it. So watch out for the bad actors out there. Did you have anything else to add?
I think one thing that, I have sort of learned, let's say going through this, that, if this, I think it does make sense in regards to being able to help with fatigue, given the potential benefits on just energy and injury handling. There is so little out there right now to treat the massive fatigue that can come with PD. I think that reason alone should make this, of interest to study a little bit more rigorously, because there's just really nothing else that addresses this well.
Totally agreed. So then, is there harm in extra vitamin B? Now, how have we talked about with vitamin B1 specifically? We've never really observed harm. You find that throughout medical literature.
You can have side effects, but it may not be toxic and kill you, I guess is another way of putting it. Yeah.
So, but when you hear vitamin B, keep in mind, there's like a dozen B vitamins, and not all of them have the same safety profile. So for example, there can be adverse effects to too much of all the Bs, particularly B6, as Amber mentioned earlier. And this could lead to increased risk of things like bone fractures, heart disease, heart arrhythmias, and certain cancers. So
I want to, do you have anything on B6 specifically? Because this is an important
I don't
public
call
safety
out B6
announcement.
specifically.
Yeah.
So
this has happened more than once. Let's put it that way. Enough that I want to bring it up here. But I have had to see patients in the hospital with weird, vague symptoms, and a lot of it actually is a neuropathy. So this is like, it can be, pain or change in sensation, usually the arms and legs, hands and feet sort of situation. And in some of the cases that I'm coming to mind right now, it really was because of excess B6 specifically. So what happens is people are taking, a multivitamin and then maybe also a B vitamin, and then maybe in this one case, it was an energy drink. And those energy drinks are often very high in B vitamins because it helps with fatigue. And then what happens is, like, all these different sources then give you just big boosts in B6, and that actually can be quite toxic at not very high levels. So it's really important to look at all the ingredients that are in these things. And this is why I had mentioned in the chat that you're probably more likely to see a B complex than just thiamine alone on the shelf. That you can get that. But just be aware then all the other supplements that you may be taking. A lot of times, these things don't come up in the doctor's office. So I think it's really important to look at, again, all the ingredients and everything you've got, because it's the additive effect. So when you put these things together, it can be harmful.
Absolutely. So actually, that's where I was going next. So many supplements already contain a whole list of B vitamins. Often they don't contain B6 because of those issues, but sometimes they do. And then there's some of these supplements that are being targeted towards neurological disorders and neurodegenerative diseases. And they are high in all of the B complexes. And it only takes taking, they're supplements. So there's no rules against how many you take or how many you take together. That's why you always have to talk to your doctor to look at medication interactions. And supplements are medication. So when you're talking about the medications you're taking with your doctor, talk about your supplements, talk about your diet too. That all factors in. So while combating a deficiency in any of the B vitamins is important, just keep in mind sometimes too much of a good thing can be just as bad. And honestly, if you're eating a balanced diet, particularly a Western diet, if you've got whole grains, if you've got legumes, you're probably getting enough of your B vitamins already. So the real question here isn't about B vitamins, it's about B1. And it's about thiamine and about the thiamine protocol. And that's where it's, again, talk to your physician about your supplements. So where does that leave us when it comes to specifically thiamine for Parkinson's disease? And as Amber mentioned earlier, probably the best summary on what we know was actually already done for us. There's an excellent web page from about 3 years ago on the Michael J. Fox Foundation website with the link there provided that sums up thiamine and the B1 protocol for Parkinson's very nicely. And sums up what I've also been talking about for the last 40 minutes. Specifically, yes, there's a few studies that have found an association between low thiamine levels and Parkinson's disease, but the studies had notable limitations, and there's no conclusive evidence that there is a genuine thiamine deficiency in PD or PD neurons. There are case reports, 2 small open label clinical trial studies looking at the high dose oral and injectable thiamine, and it showed improvement in the patient's symptoms. But the trials do not include a placebo group. The trials were small, at best phase 0 to phase 1. And they weren't very long. The one only went out to not even 3 years. And while they said scores remained stable, they did drop and then stayed dropped. They did start creeping back up over time. So the general summary that I have and that Michael J. Fox Foundation also came to is that at this time, the scientific evidence is not insufficient to recommend thiamine for Parkinson's. Now, does that mean it's no good? No, I didn't say that. What it means is we need more evidence. We need some more basic science. We need placebo-controlled trials. We need larger numbers to see what's really going on here. Because even though the studies have been small, it's hard to deny that there's an effect. But what that effect is, how it's being caused, and can we make it better by titrating the doses, we don't know those things. And it would be really good to know those things.
And I'm really wondering, again, after digging into this topic, is this really better for like symptom benefit and not disease modification, right? And that those are very different ways of, asking if thiamine's helpful. And it's a different type of study that you would do. But I think, again, going back to this idea that maybe it does help with fatigue, that there's a lot of anecdotal evidence of that.
Yeah.
That's a very different study and way of thinking about what thiamine's doing than asking for it to slow down disease progression, which is a lot harder to ask.
And if you go to the B1 protocol website, under their science section, now I want to stress caution when it comes to that website, because while there's a lot of facts, a lot of links, a lot of information on there, don't use it as a how-to guide. And keep in mind, while they want to help people, I'm sure they want to help people, it's definitely written from a perspective of spinning it to their benefit, trying to sell you something. So, I mean, they obviously have nothing for actual sale on their website, which is commendable. They're advertising the protocol. They're not selling, hey, come buy our B1 therapy. And that's actually really refreshing. But, take it with a grain of salt still, because again, we don't have the evidence just yet. And as Amber said, maybe this is all about turning fatigue around, and that's great. If you look on their website, Dr. Constantini's group has actually tried this in about a dozen different disorders, both neurological, metabolic, gastrointestinal disorders that have fatigue as a major symptom, and have found that it's improved symptoms in a lot of these cases. They've actually even tested it most recently in cluster headaches and bowel inflammatory disease, and saw improvement in symptoms in both of those cases. But these are one-offs. These are very small studies, and they've yet to provide us with the actual mechanism of why. So it's great that there's an effect, but we need to know why before we can actually go about recommending this. So again, if you're considering thiamine at all, or any supplement for that matter, that is not part of your prescriptions from your doctor, talk to your physician, make sure it's not going to interact. Thiamine shouldn't interact with anything, but make sure that you're not doubling or tripling up based on what you're already taking, and let them know what you're taking, so that if they see changes, or if you see changes, they know what's going on and can work from there. It's communication is very, very important. Cannot stress that enough. And that's what we have when it comes to thiamine and Parkinson's disease. It's a nice. I just want to finish off with it. It's a nice start of a story, but we have a lot more work to do.
It's perfect for Donna's next question. So, what is do you know if there's any further plans for studies?
I do not know that.
It can be hard to know if there's a group out there that's interested in looking into this. And sometimes if it's small, or they're trying to keep it under wraps, they may not have it out in the public.
And the other issue is that this is a small Italian medical research group. They seem to be just kind of getting the permission to, hey, we've got this protocol, we know it's safe, we're just going to start putting it in different diseases. So I don't know, in Europe or in America, if there's any thiamine stuff going on right now. I would head over to clinicaltrials.gov and just look at thiamine Parkinson's and see if there's anything there as a starting point.
And just to add, one of my concerns with this is that, this is a supplement. There's no upside for, a company to take on a vitamin and use this as, to put in a big study for Parkinson's disease. So this worries me in regards to its ability to, become, legitimate in the field. This is a problem with all the repurposed drugs. There are a few companies that have sought it to do this, but there's a lot of interesting compounds that even I've worked with that look really good, but they're old and they've been on the market forever. And trying to spark that interest in pharma is almost impossible.
So Donnie, you asked for the website for the B1 Parkinson's protocol. Yeah, I had it on one of the slides. I will put it here in the chat for you. Again, it's written in a very upbeat way. So I just want to caution you against about that. Hold on a second.
Donna, do you have another question?
Was trying to get it on my I wondered, did you look at this book, Parkinson's and the B1 Theory by Delphine Bryan? And there's another guy that's running this, is Sergio somebody, and they have a Facebook group. It's not a website, but they have over 8,000 users. all over the world testing out B1 therapy on this Facebook group. And it's based on her book. And along with that Facebook group, they also have a lot of articles that have been written supporting the B1 protocol and what to do when and what brands of supplements. And they give you a lot of advice. So I think instead of Parkinson's people waiting for clinical trials, they're running out of patience and they're doing it themselves. And they're seeing results, and that it may not delay the disease, but it gives you enough movement that you can exercise, which does prove to delay the disease. So the whole goal here is to get rid of dyskinesias, dystonia, slow move, bradykinesia, so you can move, because that's the only thing that will affect what's going on. So I don't know, are we considering this body of work that they've created on Facebook?
If I may interject here, Donna, it's exactly what you are referring to that brought us to this discussion point today. So we are hearing about more and more people in Europe who are freely doing this. It's very common, and they've expressed surprise that we're not doing it here in the US. And Dick Thompson, who is on this program here and held up the book with you, had a really good experience with it. And so I'll let Dick talk about his experience and what the next steps are for people who are interested in being part of a little group to study and document this, and with the potential of going to a wealthy person who may be willing to fund the research. So I will turn it over to Dick Thompson, who's a member of our PD community.
Is he from
Just
Pittsburgh?
and I
Yeah.
need to leave.
Pardon me?
Right.
Thanks, Christine.
Have a good weekend, everyone.
Guys,
I wasn't looking for this therapy. I just seemed to stumble across it back this past late winter, early spring. And it intrigued me, and I started to do some more research into it. And understanding that vitamin B1 is a water-soluble vitamin, I understood there'd be very minimal risk of any sort of issues with overdosing. And the first thing I did was I sat down with my neurologist during my 6-month checkup and talked to him about it. And he just said, well, he doesn't know much about it. There's not much out there, which we've heard from Victor and Amber today. But he said, just go ahead and give it a try. And so I started this back first week of April. And the protocol that I used was to increase my dosage every 2 weeks. And I got up, as I said earlier, I got up to 2.5 grams per day after about 4 months, I think it would have been, because this would have started to experience this in October. And at the same time, I had with my PCP doctor, I had my annual physical. And we talked about a little bit about that with him, and I'll come back to that before we leave this. But I didn't really realize a whole lot of improvements, but they came very subtly. The one, my wife commented that I was moving much better. I was more fluid. I wasn't hunched over. I wasn't taking small steps. I noticed that when I went to do some typing of emails, I said, holy cow, I just typed that email with my left hand, which I hadn't been able to do in months. And another eye opener was I had to change the batteries in my chest strap transmitter for my heart rate monitor. And it's like putting the batteries into a watch. You get this little tiny screwdriver and little tiny nuts or screws. And no way could I have done that if I hadn't been on the B1 therapy, because I had lost all the tremor in my hand. And in the back of the book, which Donna showed you, there's a checklist of symptoms where you want to check to see if you had improvements. And the one that I really noticed the most was just a general overall feeling of much more healthy, much more well-being. I didn't have the blahs. I didn't have the constant aches and pains. I was far more energetic. I was able to decrease my Parkinson's meds, which is the Sinemet, by 1 pill per day, which I was very comfortable with. I was pleased with that, which is kind of a bonus of this. And when I went off of it, the reason I went off of it is because I went too fast. I've been accused of being a greedy person, and I guess my greed was, more is better. Well, it didn't work out that way, and I didn't document. I didn't keep the notes and diary that I should have been keeping it as to when when I first noticed that these symptoms had improved. So I started that whole process over again, and I've been back on vitamin B1 now for 8 weeks. And I dropped my dosage down from 500 milligrams to 250 milligrams for my incremental increases. And just in the past few days, I'm experiencing some increase in energy. One thing I commented on to my wife today is that I feel that it feels like I take my morning PD meds around 6:30 in the morning, and I can really feel them wearing off by 11 o'clock. Today, yesterday, and the day before, I had no sensation that my morning meds were wearing off, and I was able to extend my interval by about a half an hour to 45 minutes, which I appreciate that. But I did mention what I was up to with my PCP, and I kind of reiterated everything that we heard this morning or this afternoon about the lack of a clinical study, and I shared that with my PCP. And I said, before we get the neurological people to start, recognizing this as a viable alternative therapy, we need a clinical study. And I said, it's going to be very, very difficult to get anybody to pay for this, because I'm after what we heard today, it's going to be expensive. And my PCP said, well, I've got somebody, he's a friend of mine, who he thinks would jump all over this, who's got lots of money and would be willing to put up the money to do the clinical study. And so I thought about it, and I said, well, okay, let's start working on this. And so that's why we got this meeting today, because I didn't want to go to this guy with the money and say, this is my situation, this is my experiences, this is what I saw. I would like to get anywhere from 6 to 12 people and do their testimonies and put these in front of them, so we can say, hey, there's a group here in Western Pennsylvania or wherever that have experienced real positive results from taking the B1 therapy. So that's where we're at. I met with Christine earlier this week, and we decided to do this Zoom meeting. And my hope is that from this Zoom meeting, we can get people to volunteer to give this a try, and we would get it officially started sometime in January, and just document it and follow the regimen and see what they experience from it. And then we can take this and put it to this individual with the money, and hopefully they'll be convincing enough that he will put up the money to go ahead with the clinical studies that are needed to make it a viable, legitimate alternative therapy for helping people with Parkinson's. And it's not a replacement for traditional medicine. It's a complementary type of procedure. The key is to find the sweet spot, is the amount or the volume of B1 that is being the most effective for you. And if you have to cross the line where your symptoms come back a little bit or they increase a little bit, well, then you know that you've hit your sweet spot and you can back off and just stay at that amount. Right now, I'm at, as I said, 1 gram per day, and I've been on that for a month. And 1 gram per day. I'm at 1 gram per day, and I've been at that for a month. And I'm starting to notice a difference, and I'm going to stick with it, and for the next couple of months. There was some questions I saw that come up about the availability and whatever of vitamin B1. This is not the one I'm using, but it's the one I would recommend as we go forth. It's the one that was used by the gal who wrote that book, Donna. It's a superior source B1. It's sublingual, which means it goes right into the bloodstream. You let it dissolve underneath your tongue. And I think in the book she was talking about taking 100 milligrams 3 times a week, like a Monday, Wednesday regimen. Well, this box here, which you can buy on Amazon, it costs $6.80, and there's 100 capsules in here. So that's a month's supply of vitamin B1 to get this started. So, and there's other forms that you can use too. There's been some caution raised about the B1 formulation known as benfotiamine or benfotiamine, which is a fat soluble B1, which I'm not too enthused about, which means it's not going to be dissipated from your body. On several of the other things that I've read and seen on vitamin B1 therapy, they say that there's a B1 formulation known as TTFD, which I need to do some more research on, because they say that's the most bioavailable, meaning it's the most absorbable by the body. But I don't have an opinion on that yet. But that's our plan. You just go ahead with this and see what we can do, and maybe sometime next year we can put a proposal to this guy with the money and start moving forward with a legitimate, comprehensive clinical study. And I think that one of the things that I look at and what I'm seeing here, feeling here, is that I see this as an opportunity for us as individuals or us as a group to have a positive impact on the people living with Parkinson's throughout the world, especially in the United States. Okay.
Did you use the Facebook page?
No, I don't do, I can't figure Facebook out. I need to get my grandson in here to show me how to do that.
So you read her book and just did your own research, but not.
I read my book, and there's another website or YouTube channel called what's it called? No Silver Bullet.
They have the good B1.
And they got a lot of good information there on the B1 therapy.
Right. That's where I first heard about it, was through No Silver Bullet.
No Silver Bullet, and then EQ Nutrition does. EO Nutrition has a good a lot of good stuff to look at too. Because
what I'm thinking, we're trying to organize people in Western Pennsylvania, but that Facebook group already has 8,000 members that we can benefit from, and it all over the world, and we could. I don't know if they're keeping the data from these people, but
I think part of the problem that a clinical study has not been done is that Dr. Costantini passed away.
Right.
And any project like this, it takes someone to assume ownership for it with a passion for it to get it done and really push it forward. And I'm guessing that has been lost with the passing of with his death.
Well, on the Facebook group, you're getting guidance from Daphne and this other medical doctors. Right. So there is the people picking up the torch from his work, and they have an order.
But I'm talking about the funding to do a clinical study. In fact, she's taking the funds from the sale of her book into a GoFundMe page to help raise funds for a clinical study. Okay. But that could be a long ways away.
And it's important for us to say that, kind of like Victor and Amber Van Laar, we're not endorsing this as an organization, as PFWPA, but we have seen evidence of how this has helped people. And if you're truly taking B1 and only B1 and are cautious and maybe get some coaching as a group from people who have been through the therapy, perhaps it generates an interest in this wealthy funder to do clinical trials that pharma is decidedly staying away from, because
they're not going to do it because they can't patent it or copyright it, and it's available at any supplement store. I'm sure you can get it at grocery stores, Walgreens, Amazon.
Right, and it potentially reduces the need for their pharmaceuticals. So I think the next steps would be, if after hearing this and thinking about it for a while, if you have an interest in being one of the 6 to 12 people who are going to participate in this, then reach out to PFWPA and let us know, and we'll stay in touch regarding next steps.
Thank you, everyone. And
I think he's going to participate.
Okay, and if Dick, are you willing to share your email address, or can we share it if someone emails us if they have questions?
I'll give it right now. And you can share it. But if you want to contact me, and I would like to start out sending some more videos to people so they get a better understanding and study it. But it's D Thompson, THOMSON 717 @gmail.com. And again, it's D Thompson, all lowercase, THOMSON 717 @gmail.com.
And it looks like right now we have Tim Carrera and Vicky Herbert on board along with Dick, and we have some previous names. We'll see if they remain in after this presentation.
Okay.
Carol Galbraith.
Yeah. And I did type your email address in the chat box as well, Dick, so.
Okay.
Can you just share with us how long you've had Parkinson's? And what your background story is, how you think you got it?
I was diagnosed with it about three and a half to 4 years ago. But I had been working with folks with Parkinson's at the Oxford Athletic Club, where we had the boxing classes going on. And I looked and saw many of the symptoms that I was experiencing in them. And I go back to probably 2016, 2017, when I started experiencing the symptoms that led me to really investigate the fact that you got Parkinson's. I had lost the use of my left leg in pedaling my bicycle back in 2016. And that was a real eye opener for me.
And who is your neurologist that is aware of your B1 therapy?
Dr. Tim Licklider.
Okay, great.
And you may not know this, but if you may recall, 2 years ago, a group of 10 riders rode from DC to DeBerg and raised an awful lot of money for us. And I believe 4 people on that trip. Jim Steele is on here too. He helped on that ride as the SAG, but 3 people with PD rode from DC to Pittsburgh. So Dick is also an active exerciser, which may increase how this works for him too. So another plug for exercise.
And can I ask you one more question, Dick? How much Cinnamon do you take?
How much cinnamon do I take? I take right now, I'm at 5.5 pills per day.
Every like 4 hours, 5 hours.
Yeah.
He doesn't take it at night.
I take one. Dr. Licklider told me to take one at night because it deals with helps with my anxiety and helps me sleep better. But during the time where I was really doing well with the B1 therapy before I OD'd, I had decreased it down to from 6 to 5 pills per day.
And you take regular release Cinnamon, not the extended release or Dietary?
Yeah, it's the regular release. Yeah.
You don't take Dietary?
No.
Oh, any last questions for Dick or anything you'd like to share regarding this before we conclude?
And I've written down the names of Vicky, Tim, Carol, and Ed as potentially interested. And if anyone else wants to reach out, please do so.
This was wonderful. Thank you, everybody. And thank you,
Gotcha.
Doctors Van Laar and Dick Thompson in particular. Have a nice Thanksgiving.
Yeah, you too.
Thank
Bye.
you.